Hello, everyone. This is Barb Cochran. I am speaking to you from my laptop, so you're not seeing my image, but we're here and we're really glad you've joined us today for the first of our two rescheduled talks that were previously canceled because Seattle had some unexpected out of the ordinary snow that kind of closed things down for a while. I also want to mention, because this is the second to the last lecture in this series, that you should contact your site coordinators if you're wanting to get continuing education for this series. They will have the information for signing up for continuing education credits. And then I also want to mention that the Spring Geriatric Healthcare Lecture Series is starting up on April 2nd, same time. And that series will be more general geriatrics lectures, and so you should have from your site coordinators the full list of those 10 lectures that are coming up. And today I'm really happy to introduce to you Kristoffer Rhoads. Dr. Rhoads is a clinical neuropsychologist. He's specializing in the evaluation and treatment of dementia and neurodegenerative disorders. He has held a variety of clinical teaching and research positions at the Seattle VA Medical Center and is Director of Rehabilitation Neuropsychology and co-director of the Memory Wellness Clinic at the Virginia Mason Medical Center Neurosciences Institute. He currently serves as the primary neuropsychologist for the UW Memory and Brain Wellness Center at Harborview, and Dr. Rhoads has published in the areas of dementia, continues to conduct research and trainings, and currently serves on the board of directors for the Washington chapter of the Alzheimer's Association. And he was recently appointed as chair of the Health Medical Care Subcommittee for the Washington State Working Group to develop a state plan for Alzheimer's disease, has incredible expertise in this area, and he's going to talk with us today about a really important topic, which is driving and dementia. So welcome, Dr. Rhoads.
Well, thank you very much. And oh my gosh, just rousing round of applause from the three people in the room. That's much appreciated. Well, thank you. And thank you for the invitation to come talk about this. So I'm a neuropsychologist. I am not a researcher. I am involved in research, I'm involved in education, but I really identify as a clinician. And within my clinical work, I do two things. Part one is the assessment of cognitive function and the differential diagnosis of, I've got memory problems, why do I have memory problems? And then the other part is the treatment of those things, the non-medication, non-pharmacological, and behavioral interventions, kind of rehabilitation, neuropsychology oriented. So I'm kind of coming at this from that avenue. And I also appreciate the opportunity to reschedule this. We have unusual weather here again in Seattle, but the 80-degree temperatures don't seem to shut things down, unfortunately. And my apologies too, I'm either battling allergies or a head cold, so my voice sounds kind of funny to me. And we'll see how we do. So just kind of first and foremost, being a neuropsychologist, I have no disclosures. No pharmaceutical companies are banging on my door to sponsor any of my activities, so I really don't have anything there. And I do also, again, kind of from that clinical focus, I would offer you in the work that we do at Memory and Brain Wellness and in the work that I do as a neuropsychologist, driving is probably the hardest discussion to have. The disclosure visit around a diagnosis is one thing, but when you get into the what does this mean and what does this mean particularly around my community mobility and my driving quote unquote rights, it's really difficult. And for those of you who do this work and interact with patients and families where driving is an issue, I don't need to tell you that. So my hope is to give you some resources and some practical tools to talk about how does screening and assessment of driving fit into clinical flow and clinical work, and then to talk about, what are the major risk factors. So with the state plan work, you're reminding me that introduction maybe needs some updating. We have formulated our state plan here for Alzheimer's disease and other dementias in Washington, and we now have a new working group that is implementing that state plan, and driving is part of that. So I'll give you some resources around that too, now that we've done some of that. Helpful to think about kind of a case, and this is a representative, fairly recent case from our clinic. This is a 73-year-old female who has short-term memory difficulties. She has not noticed, but her family have noticed some changes in personality. She's starting to kind of tread the line of instrumental activities of daily living being affected. And that includes a recent questionable fault accident where she was at a four-way stop. Wasn't clear kind of who got there first, and fortunately it was a low-speed collision, but it was an accident nonetheless. And one of her concerns and her kids' concerns was, is the insurance company going to cover this? And if there's something neurological at play, what might that mean in terms of liability and fault? And of course, what does it mean in terms of future risk for an accident? If there is something neurologically wrong that's driving this. And her primary care provider, who referred her over, had a question of, well, with the personality changes and the memory, is there some depression at play? She's got some vascular risk factors. Could it be, microvascular ischemic change, or is there something more neurodegenerative? And of course, it's kind of rare that it's one and not a little bit of two of these, or maybe even all three. But that's the classic question of, is it this or this or this? And then what do we do? I'll tell you a little bit more about her. So when we sat down and talked with her, she's got a 2-year history of gradual insidious onset difficulties with name recall. She's having trouble with spelling. More kind of esoteric low frequency words, not necessarily common words. A lot of tip of the tongue dysnomias that kind of hand me the, the thing that you, calculator, that kind of thing. She's having trouble remembering recent TV shows and movies, old ones that she's seen a bunch, no problems. And then certainly difficulty with short-term recall for conversations. So this is a pretty classic, almost everybody, if you probe enough, will say, yeah, I've got some degree of change here. Whether it's pathological or not, or whether it's reflective of a neurological process or not, it's a different story. No hallucinations, no neuropsychiatric features, no fluctuations. And then the behavioral changes are really commented more by her children and her spouse, that she's increasingly irritable. Her fuse is pretty short. She's easily frustrated, things that she normally would have kind of rolled with and not had too much of a problem with, now really tick her off. She has been physically aggressive with her husband, not to the point that you're thinking of a APS call, but certainly it's a behavior change and not consistent with her history. And no problems with her basic activities of daily living. A little hard to figure out in terms of finances. Husband always did those. And medication management, she doesn't have too many on board, except for all these vitamins and supplements. No alcohol per her report. And then as you dig a little bit more, well, I have wine with dinner. And then it's, well, I have a glass of wine before dinner, and then I have a glass of wine with dinner. And you always have to ask the question of, is it a glass or is it a glass, right? This is where it's helpful to talk to the family separately. No neurological history, depression history that, although fairly well controlled per her report. And she's well educated, 17 years of education. She's a teacher, had a teaching certificate on top of a bachelor's degree. Bright, so no history of learning disability or attention deficit disorder. And she's incredibly active in her community. Drives everywhere because she has to get to church, she has to get to her book club, all these things. And doesn't live in a place where there's a lot of community transit. So there is current legal involvement around the accident. The other parties are contesting that it was not their fault. Because of the behavioral changes and the agitation, there's some historical, now reactivated marital therapy. She and her husband are still living in the same house, but they're in kind of two halves of it. She's upstairs, he's downstairs. The kids are now more involved in her relationship, in her medical care, but historically not a real close family. And it seems like because of her personality changes, friends aren't calling her up for lunch quite as much. She's having trouble with socialization. All right. So again, this is not an uncommon story. This is not something I think that's unique to our clinic, a tertiary kind of specialty care center. When you sit down with her to do the clinical interview, you observe that she is all over the place emotionally. She's happy one minute and then kind of angry and irritable, particularly as you try to rein her back in. She starts kind of going off on tangents and it's not really answering the question that you need answered. She was very, very perseverative about the accident, that this was not her fault. She had gotten there first. There was a good 2-second delay, and just kind of keep coming back to that. And then it was hard to tell. I mean, these visits, especially a full neuropsych eval, are anxiety provoking and scary and stressful. And it's possible that she was anxious. It's possible that she was just kind of fidgety and restless. But she certainly seemed to be ramped up. So I'll be asking you to think about, as we talk about different forms of dementia, and I know you have gotten an excellent overview of different neurodegenerative and other neurological conditions that yield dementia and cognitive impairment. So we won't go into those in great depth. But in terms of what you know and what we revisit today, thinking about what might her diagnosis be and what might that mean in terms of her driving ability. And as we think about the three differentials that were offered by her primary care provider, depression, maybe something vascular, maybe something neurodegenerative, those are all going to have different bearing and different weight in terms of her community mobility and driving. As we kind of shift into more global things, you don't have to look too far in the news to come up with all sorts of headlines across our nation that involve driving and dementia. Sometimes they're fatalities. Sometimes it's the silver alert where somebody's missing and was last seen, headed east on I-90. And often, if you read these articles, you'll find that alcohol is involved as well. But these stories they're increasingly frequent as our prevalence rates for dementia go up, and certainly attention-getting. And just as we kind of think about, overall background, I think of driving as something that really capitalizes on procedural memory, and that's both good and bad. When we think about changes in cognition that accompany, especially Alzheimer's disease, where mesial temporal lobes involved and short-term memory, whether it's encoding or storage is affected, kind of behavioral patterns and habits that circumvent that by running through the cerebellum and other networks are pretty resistant to change. So you'll get people who can't remember recent conversations, but they don't forget how to drive, right? And driving is this really overlearned thing, right? You don't have to get into a car and think about, I have to turn the wheel this much to get the car to head, left at that corner. I have to push the gas pedal down this much. You can think about all those things, but you don't have to, as it pertains to just getting in and driving. And I mean, ask how many people have found themselves 20 miles down the road and have no clue what they were doing or observing as they were driving, kind of on autopilot, especially on the freeway. That happens. But when you look at what's involved in terms of complex attention, so divided attention, selective attention, processing speed. So one of the things I usually talk about with families is, you might be fine in certain driving conditions, but what happens when the ball comes out in the street and the kid comes out after it? Can you process that information, especially visual information, that quickly and then react appropriately and get your foot to move from the gas pedal to the brake, right? Visuospatial skills, so depth perception, both the dorsal and ventral stream of our visuospatial system is critical in driving, so object recognition as well as spatial or placement. Executive functioning, that ability to look at a car and estimate speed and think about, okay, if I pull out now, do I have 2 seconds to get out? Do I have 10 seconds? Inhibition, I see something happen and have to put the brakes on it. And then of course, memory, which really, I mean, of all these cognitive functions, memory is probably the easiest one to compensate for with GPS or having a co-pilot who tells you, turn, in next street up here, turn right. But these other things are hard to compensate for. I will also ask you to think about driving, or kind of remember that this is, I hinted at this being a really incredibly difficult thing to talk about with most, not all, but with most patients and families, is that, driving is not a right, it's a privilege. We forget that sometimes. And sometimes it's I want to be able to go to the store when I want to go to the store. Yeah, I could get on the bus. I could have a family member bring me. Sometimes it's the store is 10 miles away because I live in a rural place and there's nobody else around here to drive me. So there's sometimes need, or I'm the only driver for my friends who have medical problems and I need to take them to their appointments. And then of course, it's not just transportation, it's identity. It's kind of our sense of purpose and mastery, and this is really hard to delve into sometimes. But because of these things and because of the consequences, I've been subpoenaed by the Secretary of State here in Washington in a case where we had a woman with early Alzheimer's disease who had severely impaired selective and divided attention, visual spatial skills, and executive functioning. And we made the recommendation that she should not drive. She, as we hear this often, says, thank you very much for your opinion. I've been driving for longer than you've been alive, and I'm a better driver than you are. 3 months later, she got into an accident and killed her sister. And the Secretary of State was pressing manslaughter, motor vehicle manslaughter charges, especially because the recommendation was in her chart that she not drive. So there are huge ethical and legal dilemmas that come up with this. And what is it that is our duty to warn or to kind of protect the public and our patients and families? So thorny issue, and not usually addressed in a kind of a 2-minute conversation. Also just some kind of basic background things. Interestingly, it seems a little bit counterintuitive in a way that, of course, driving skills are inversely related to severity of cognitive impairment. But those with the mild impairments have the highest risk because they're driving the most, right? Usually by the time somebody's hit mid-stage or late-stage dementia, they have either retired from driving or been retired from driving. But with mild dementia, especially for people who don't have a lot of awareness around deficits, there's really not any kind of behavior modification or change in driving habits. And the other interesting thing about this gray area is that the vast majority are probably safe to drive in most scenarios. So you can't make a kind of a uniform cut point of, once your CDR hits 1.0, you've got to retire from driving. It doesn't work that way. And it certainly doesn't work to say, if you've got mild cognitive impairment, you should retire from driving. Some people should. Most probably shouldn't. Should you be thinking about what is my plan to retire from driving? Yes, absolutely. Should you be crafting that plan and making some steps towards it? Absolutely. And then the other thing to know about this is that it's very, very hard to assess this in an office visit where you do something like the mini mental or the mini cog or some other kind of screening measure. It may be more helpful to have objective cognitive testing, and there may be some benefits to a comprehensive neuropsychological evaluation, but the thing I tell providers and patients is a neuropsych eval is not a driving evaluation. We will assess cognitive constructs that go into driving capacity, just like we can assess cognitive constructs that go into testamentary capacity or medical decision-making capacity. But if you really want the gold standard evaluation, you need a driving-specific evaluation. But sometimes cognitive testing is such that the person's not going to pass that. Why make them do it? So we'll talk about that too. Okay. You've heard this, I think, in other presentations, so I won't dwell on it. But this also is an increasingly frequent thing in the media because we've got so many more people with Alzheimer's disease. So the facts and figures came out last week for 2019. We went from 5.7 million Americans with Alzheimer's disease to 5.8 million Americans, which is the lowest incremental increase over the last probably decade, which is interesting. But we still have this huge population that is aging into risk for the disease, right? So even though we know Alzheimer's disease is something that starts in midlife, 65 remains kind of the average age of onset for clinical symptoms, and there's a huge cohort that's just kind of right there right now. Here in Washington State, and my apologies to those of you out in the other region that I don't have your state-specific data, but you can find it on the Alzheimer's Association facts and figures page. There's a state-by-state set of data. We have 110,000 cases of Alzheimer's disease and other dementias here in Washington. That number is the same from last year to this year. But we'll go up to a projected 145,000, maybe 150,000 by 2025. It remains the third leading cause of death in our state, but we are now number 9. For many, many years, we were number 3 behind North Dakota and South Dakota with the highest rates of death due to Alzheimer's disease in the United States. And that's not necessarily because we have so many more people who die of Alzheimer's here. It's that we do a better job of kind of public health accounting, that when it's Alzheimer's disease, we call it Alzheimer's disease instead of just saying pneumonia or respiratory failure. And other states have kind of done the same thing. We were number 5 last year, now we're number 9. And of course, as we were crafting the state plan, we kind of had to remind ourselves that this can't just be an I-5 corridor, Seattle, Everett, Tacoma plan. It needs to serve those who live out in Omak, Wenatchee. I was just in Spokane last week, and the programs and services there in Spokane County or down in the Tri-Cities, even though those are kind of urban hubs, so different than what we have here. So thinking about how do we build things that are equal and at least applicable across the state. You also know kind of the what's normal, what's not here. So we've got kind of in green the normal curve, and around 65 is that first drop that happens. If we play this out a little further, around age 85, there's another drop that happens that's maybe a little bit progressive, but it's certainly not to the point where function's impaired. And contrast that against kind of the neurodegenerative curve here, where there's enough of a deviation over time from normal aging that we fall into the territory of mild cognitive impairment. We then kind of hit the territory of dementia as we progress down that pathway. And then there's some endpoint that we can think of as a treatment target. This could be stopping driving. That's probably going to be up a little higher. It could be death. It could be placement in a more structured living environment. So I kind of think of it that way. And we also, over time, and I think you've heard plenty of this as well, we have a good sense of kind of what changes as we get older and what doesn't. So we know that things like crystallized intelligence, our procedural memory, so kind of back to that habits and behavioral memory, tends not to change. Long-term memory tends not to change. Our capacity for working memory probably doesn't change very much, but our speed of retrieval and access does as we get older, given that processing speed is one of the main things that changes. So we've got a good overview now of what changes, what doesn't, and we know at around age 50, there's about a 9% decline in some of these cognitive domains per decade. So it's not insignificant. And I'll just remind you, if it's been a while, that, again, mild cognitive impairment, we think of as you've got memory problems or problems with some other cognitive domains. It's either a standard deviation and a half away from people your age, education level, or maybe your abilities. So I see a lot of faculty members. I've seen chairs of departments. I've seen CEOs, people whose premorbid abilities are in the superior range. And when they're scoring in the low average range on measures of selective attention and memory, that's worrisome, right? Because you're going to guess that even given strengths and weaknesses, everything was a little better than average probably. So you can look at the data a couple of different ways. But otherwise, people are doing pretty well. So MCI, this is the person who's saying, yeah, it's hard for me to remember where things are in relation to each other. I know I'm here, and I know campus is over here, or Harborview is over there, but the streets that I would take to get there, I can't picture it. And then I get lost, and I kind of get stressed out. But I'm using my GPS every time I go to the store, and I'm doing just fine. That could be MCI. Right? Or, boy, it's really hard for me to remember my medications, but I've got this great Mediset with an audible alarm on my phone and then a check sheet so I can tell if I took them or not. They're functioning well. They're compensating and adapting. We also know that if it's purely memory related, about 10% convert to Alzheimer's per year. If it's memory and executive functioning, it's probably closer to 18% that go from MCI to dementia with functional impairment. And then, of course, the type of MCI you have potentially sets the stage for the earlier prodromal phase of what's causing it, right? So people with visuospatial and executive dysfunction may be early Lewy body or MCI due to Lewy body disease. If it's pure kind of language problems where it's halting and hesitating, it might be right temporal lobe variant frontotemporal dementia, right? So we know that this is sometimes the early identification of other disease process. And we also know that about 10% of people with MCI go back to normal aging every year. And these are the folks that come in and have untreated or undiagnosed sleep apnea, undermanaged depression, alcohol overuse. Rarely it's a thyroid problem or a B12 problem. That's usually checked out by the time they come see us. So not everybody with MCI is due to a neurological problem, and certainly not everybody progresses to dementia. Hence the importance of an early workup, medication side effects, of course. And then again, I know you all know this, but I include it in every talk, and I've promised people I will include it in every talk that dementia is not synonymous with Alzheimer's disease. As you know, it's just a syndrome of acquired impairments that causes problems with day-to-day function. And when we think about the odds, actually I'll skip to this page here, probably small to read in your handouts. I am happy to send either individual slides or a PDF version of this if you want a larger version, but kind of summarizing what I'm sure you've already heard in this series, that most common is Alzheimer's disease, representing 2/3 or 3/4 of all dementias, at least as a primary, if not a secondary component. Vascular dementia, probably the second most common, although dementia with Lewy bodies, second most common neurodegenerative form of dementia, and then FTD, fairly rare. And again, just an overview of the parts of the brain that are involved, and of course, some associated factors. So we learn more and more about this. And we also know, and you've heard this I'm sure, is that as we age, our risk for Alzheimer's disease goes from about 3% at 65 up to close to 50% by the time we're 90. The difference, though, is that idea of having the disease versus having the dementia. So possible to have Alzheimer's disease and not have Alzheimer's dementia. And that's some of the most interesting, whether it's our monoclonal antibody studies or whether it's some of the behavioral interventions around cardiovascular exercise, diet, cognitive stimulation and activation. You might be able to suppress the accumulation of neuropathology. Somebody still has the disease, but they don't develop the full-blown clinical syndrome, or they stay in the early stages instead of the mid or late stages. I also would be remiss to not include some information, and this is a whole talk in and of itself in terms of underserved populations and ethnic disparities in Alzheimer's disease and other dementias. But certainly our African-American counterparts are 2 to 2.5 times more likely. Also true from our American Indian, Alaskan Native populations. So depending on where you practice and where you live and who your patient population is, your prevalence rates are going to be different, and absolutely your tools for diagnosis and assessment need to be different. The mini mental status examination has a false positive rate in Latino populations that's about 42% compared to 17% in Caucasian populations. So things to know. And also kind of thinking about Alzheimer's disease, because it's the most common thing we tend to see, is you can be in these 3 different kind of ranges. A pre-symptomatic phase, which may last 5 to 20 years. So that gradual accumulation of amyloid beta and tau that starts in midlife. Then if you're otherwise healthy and have MCI for maybe 4 or 5 years, you then could have full-blown dementia for 12, 15 years. I just saw somebody yesterday who has FTD phenocopy, and she has not progressed in about 3 years, even though she's got FTD, and you would expect that. So there's a wide heterogeneity here in terms of time at diagnosis, other medical comorbidities, and how long something's been going on before you've been diagnosed. I'll also point out what I think seems sometimes like an academic issue. I was at a conference last week where the presenter was saying we spend way, way, way too much time talking about these kind of nuances and neurocognitive differences and syndromes and types of dementia, when we really should be thinking about how do we just treat the person, regardless of the etiology, which there's some merit to that, but there's also some merit to knowing the underlying pathology. And here, in terms of the 2 most common variants for Alzheimer's disease, either the language variant or the posterior cortical atrophy variant. And I don't know what it is about our clinic, but we have a seemingly huge number of people who come to us with PCA type Alzheimer's disease. And an even more surprising number of them are attorneys. And it's elicited by the job tasks where they can no longer read financial, or not financial, but legal documents. And it's been a strange thing, but this is more common than I think we thought. And of course, if I ask you the question of who would you be more worried about driving, which one's it going to be, right? It's not the person with the tip of the tongue word finding problem, but really robust spatial skills. It's the person who can't distinguish, distances or gaps or object closure. So. And as we think about our second most common type of etiology for cognitive impairment, one of the hallmarks of vascular cognitive impairment is slowed processing speed, which has high relevance for driving, depending on your driving environment and demands. Certainly reaction time, muscle control, weakness in limbs, all these things, variability in attention and concentration, particularly with things that require increasing demands. So simple attention, concentration, not so bad. Working memory, a little worse. Selective attention or divided attention, as you start to tap some of those frontal subcortical networks, that's where things tend to fall apart. So this is hugely relevant for driving ability. Also, again, second most common neurodegenerative condition, dementia with Lewy bodies. Given the combination of impaired attention, executive functioning, and visuospatial skills, as well as rigidity and slowed movement, as well as fluctuation. So one of the hallmarks of this is this kind of pattern of, boy, there are some days where he seems really good and completely, or at least close to baseline, contrasted by these other days or hours where really confused, kind of somnolent, not interactive. And certainly, if that's not predictable, it's hard to schedule your driving trips around that. And then visual hallucinations. I have not yet heard of anybody who has had a visual hallucination while driving. Not that it couldn't happen, but it seems like this happens around the home more. And then, of course, related to that would be the frontal subcortical impairments in Parkinson's. You get some of the same concerns around changes in attention, visuospatial functioning. All right, and then with FTD, I don't know why that was so funky like that, but there are four kind of subtypes of FTD in terms of a couple language variants, the behavioral variant, and then a motor variant. Certainly the motor variant has bearing on operating, kind of the instrumental operation of a motor vehicle, whereas the behavioral variant, such as driving too fast, blowing through stop signs, number of accidents, these seem to be related in FTD in terms of predicting driving ability and retirement for driving. Also, as you know from previous lectures here, FTD tends to happen a little earlier, and people are still very much either working or driving or both. So this becomes quite a concern, especially if somebody is not able to participate in that meaningful analysis of, boy, let's take a look at your driving ability and these impairments and your risk. If they can't appreciate that, that's a more difficult conversation. Okay, so some kind of subtype differences that are worth knowing about. And then just kind of overall, what we know is that teens are still the most worrisome group in terms of driving, but older adults are closing in rapidly, and certainly those age 80 and above. But unlike teens, although the TBI and other kinds of sequelae from that are concerning, given how fragile and frail some of our older adults are and rates of osteoporosis, osteopenia, they certainly have higher consequences, physical consequences. So motor vehicle accounts for about a quarter of all accidental deaths for older adults. And, as much as you hear the stories about somebody who confused the gas pedal for the brake and plowed through a farmer's market, it's really the individuals that's at most risk. Those stories get a lot of attention, and for good reason. They highlight a systemic problem. We have a huge number, right? 1.5 million older adults who have dementia that drive. It's always interesting when somebody's driven themselves to the appointment and you've detected that, boy, they've got really severe impairments, and should they be allowed to drive home? Is there somebody who can come pick them up? There aren't excellent kind of if I'm worried about diabetes, we can get an A1C or a fasting glucose value. There aren't great tools for this yet. It's such a complicated thing. It's hard to have that one single measure. Also, it's kind of good to know that when you look at the data, and it's interesting too. So I did this talk a few years ago, and going back through and looking at updated studies, there's not a lot of leaps and bounds in terms of what we know. And it's really difficult because people, it's kind of like diet studies or exercise studies. The way they assess driving is very different. Sometimes it's a simulator, sometimes it's on the road evaluation, sometimes it's retrospectively. You know, it's challenging to ask somebody with memory problems, you know, how many accidents have you had? It's like asking how many concussions have you had? You know, it's hard to know that, if that's accurate. There is a pretty good correlation between things you can do in clinic and in the office with how someone does on an on-the-road evaluation, either through the Department of Motor Vehicles or maybe better through an occupational therapist or certified driving rehabilitation specialist. But again, there's no crystal clear CDR of 1, you got to stop, or a MOCA of 20, you got to stop. But I think what is uniform throughout the literature is that these things that you can do in clinic or maybe with a more expanded evaluation set the stage for who would be a good candidate for a more comprehensive driving evaluation, because not everybody can do that. It's time consuming, it's expensive. Here in the Puget Sound area, we've got probably 4 good places to do a thorough driving eval. They're all done differently. We'll talk about that in a bit, but so out in rural areas, you may have to travel significantly to find somebody that can do this. One thing that was updated last year was a nice study of primary care providers and kind of how they feel about driving evaluations and having the conversation with patients and family around fitness to drive. And absolutely, it sounded like primary care providers understood and were comfortable with assessing cognitive impairment. We actually, in the state plan work, we found that out as well. So we surveyed about 280 primary care providers in the state of Washington and said, tell us what you think about dementia and how that interfaces in a primary care setting, knowing that primary care providers are on the front lines. And 79% said, absolutely, this is important. It's important to do not global screening. There's no good evidence for that, but assessment when you have a concern or a family member has a concern. And that entire 79% almost said, we have no idea what to do. Know it's important, don't know what to do. Also, in terms of driving, would say, I know there's something in our state laws, but no clue in terms of, am I a mandated reporter? Am I an optional reporter? Is it, if we've had this conversation and I haven't referred somebody to an evaluation or followed up, am I liable? You wouldn't know that. And true for a number of things around dementia, no clue what's out there. I know there's the DMV, but I don't know if there's anybody else that does any kind of thing. And almost all of them were worried that if I bring this up and if I push too hard on this, patient's going to bail. They're going to leave. It's going to damage the relationship. And I've heard this from the primary care providers I work with who would say, I know this is a problem. I'm willing to have the follow-up conversation, but would you be the one to say you can't drive anymore, and maybe be the one to report the person to the Department of Licensing, because they're going to follow up with me. They probably won't follow up with you anyway. So, and they're worried about what it means for quality of life, right? That's going to strand this person. They're going to be isolated. Those who do more work around driving evaluations called out 3 kind of resources that are most helpful. One and top was occupational therapy. So for those of you who practice in areas with OTs, hopefully your OTs are up to speed in terms of driving evaluations. Some don't. It's kind of like speech and language pathologists. Some do cognitive rehabilitation. Some only do swallow evals. So you have to figure that out. Geriatrics and then memory disorders clinics, which those are kind of decreasing levels of frequency in terms of your resources. Also unchanged for the last several years are the American Academy of Neurology Practice Parameters. So this is available. You've got the resource there if you want to check it out. But to summarize it for you, the best evidence in terms of when you should have concerns about driving or maybe consider the conversation around retirement from driving or send somebody for an evaluation, a CDR of 0.5 to 1. And 1 was kind of the magic number. However, within that group, you can see the vast majority, if they go do a driving evaluation, do fine. But at least it gets the conversation started. The other thing that is kind of the highest level of evidence, and it seems kind of apparent, but don't rely on what the person tells you, because not just they're going to be deceptive and withhold information, they might not remember, right? So you can't just ask the person. It's like asking, in a Medicare annual wellness visit, it's a mandate to screen for cognitive impairment within that visit. There's no guidance about what you should do. So some providers ask, do you have any concerns about your memory? Nope. Okay. Check, right? Level B is the appropriately vigilant caregiver rating somebody as, ooh, I've got concerns, or there are clear areas of problems here, and I can give you stories over the last few weeks. The problem is, as you know, if you've done this kind of work or you talk with caregivers, is they bring their relationships with the person to this process, and there's all sorts of reasons that they might over-report or under-report, especially if you're interviewing them with the person in the room. So it's not, that's not the gold standard either. Level C, mini mental below 25, a history of moving violations. If you hear a story of, yeah, I used to drive all the time and now I'm really only going to familiar places and I don't drive at night anymore, not necessarily because of cataracts or glare. So these are all things that have some evidence. And there's a nice tool you can try to plug these things into. I don't know too many people who actually use this algorithm in a consistent fashion, but it gives you some guidance around things to think about and degree of risk. Low, if you have a CDR of 0.05 and maybe there's some concern, but then all the way up to you get a CDR of 1.5 or 0.5, and we already have 2 accidents and a moving violation. And then things that were kind of uncertain or unclear were neuropsychological evaluation. And you want to see heterogeneity in terms of approach. Look at studies that have used neuropsych evals in driving assessment. There are some common denominators, but wildly different measures, wildly different cut points. And then kind of, can you rehab driving? Are there things you can do either in the office or at home or out in the real world that boost someone's driving abilities? So unclear. So not that it doesn't help, but just we don't have good data. And that has not changed in the last 8.5 years. The Canadian Family Practice Parameter is kind of a nice one also to think about. And there are some check boxes here that some of them are weighted a little bit more than others. And it starts to give you an idea of what are some tools that may be important. And trail making test A and B. I would say to you that it doesn't take a neuropsychologist to administer these things. You need a little bit of training, a modicum of training, and some kind of standardization around how you do it, but you don't need to send somebody to a neuropsych eval for this. And I love the piece of including this down here in the bottom, that you have to ask the patient and family member separately. It's time consuming. In some clinics, you might not have space. Might be hard to think about what can I have the patient work on out in the waiting room while I talk to the family member, or how do I solicit this information through a letter or an email, or e-care if you're signed up for Epic. But that piece of separate, which I think you hear a lot from patients and families, especially family members, when you interview them separately. You always get the rest of the story, or at least some more of the story. I will take you through kind of what I do in terms of an assessment around driving when that comes up. And sometimes I get specific requests of wondering if this person has MCI or early dementia, and specifically wondering around driving capacity. So we will spend more of the clinical interview on this and less around how many concussions did you have as a kid, maybe, depending on what's relevant and pertinent. But getting a sense of both historic and current, how often do you drive, where do you go, history of tickets when you were a kid, history of tickets when you were an adult, more recently, questionable faults or caused accidents. That's a hard one sometimes in terms of knowing that you were the cause of an accident. But, have you been in any situations where there's an accident that happened kind of right behind you or right near you? That's not always, the person's fault, but, you start to pick up some things. Has anybody in your family expressed any concerns about your driving? Is there anybody who says, I'm not driving? If we go somewhere, or you're not driving, I'm going to drive if we go to the store, if we go to the opera, or if we're going to downtown Seattle, I'm doing the driving. Has anybody said that? Are the kids not so inclined to have you pick up the grandkids from school and soccer practice? And then change in habits. And this is always an interesting one because I will just usually ask the specific or the general. So, tell me about any changes in your driving habits, which I like because it supposes that there have been changes, right? Not have there been any changes in your driving habits. Tell me about, how your driving habits have changed over time. Well, they haven't. Oh, okay. So you're still driving at night on the rain or on the freeway in the rain. Oh, no way. Okay. And then you can start to talk about other things. Speeding. I also love the question of if you were sure you weren't going to get caught, right? You're on I-90 out by Soap Lake and you just saw 3 state police officers back that way. You're not going to get caught. How fast would you go? Right? Sometimes people will tell you. Sometimes it won't. Red lights, and you can ask specific questions around. When you see the light changing yellow, when do you usually brake? How does that work? Following distances. What's your awareness of these medications that you're taking in terms of how that might impact your driving? When do you usually take this, and then do you drive after that? Right. Yeah. So the how often have you either given or received the one finger salute, right, as you're driving around? And then to ask questions around, tell me what your wheel wells look like as you're thinking about people hitting curbs, or if you're going to make a 3-point turn, is it a 3-point turn? Is it a 23-point turn? How does that work? Navigation. It sounds like you do great with places that you go all the time, like the bank or the grocery store. But say your usual route, there's an accident or they're doing road construction. How would you do if you had to go a different way? Right? What if it was a place you only go once a month? Right? Tell me what kind of GPS system you use or have used in the past. Are you reading an actual map while you're driving? Or do you have Siri telling you where to go? And then, why do you need to drive? Right? What is it that takes you out of the house? Is it that your spouse is legally blind and you've always been the driver? Is it that your spouse just had a hip operation and can't drive? A lot of grandparents taking care of grandkids because parents are working, right? I have to pick the kids up. And then, critically important to ask all of these questions separately with the patient out of the room. You can provide a handout if you don't have time. You could, kind of write all these things up and say, circle any of the ones that you're concerned about and leave it at the front desk and we'll follow up afterwards. And one thing that I've realized over time that you need to ask is the last time they were actually in the car as a passenger. So a lot of adult children will say, oh yeah, my dad's fine to drive. Okay, when's the last time you were in the car? As a passenger? 6 months ago, a year ago maybe? And so, and then, was it going to the grocery store or were you coming downtown? Or so sometimes what we will do is say, between now and your next visit, which could be the feedback visit, it could be the family conference visit, I want you to be the passenger a couple of times in a couple of different scenarios, a couple of different times a day. Just see what you notice. You don't have to make a big deal out of it. Just say, hey, Dad, why don't you drive? And I'm just going to sit back and let you do that. And if they're not willing to do that, that's kind of diagnostic. Right? And then also, I see this conversation as kind of a barometer of how's this going to go, right? So if you're getting the arms folded and the glare and no, fine, everything's fine. This might be a hard conversation. If you get somebody who says, I've been thinking lately that I probably need to change some of my driving habits. I'm thinking about getting a new car and I'm kind of worried about if I'm going to be able to figure out how to operate it or, so just getting a sense of, what have you been thinking about and how easy is it going to be to talk about this? It also opens the door to start talking about, what is your plan going to be? We all retire from driving at some point. Whether it's because of physical reasons or cognitive reasons. So what's your plan? And usually people don't have a plan. So you can then go to the question of, what would it take? What would have to happen for you to hang up the keys? And my least favorite answer, but the most common one, is, of course, an accident. Well, that's kind of down here, right? What would be the thing before that? What would be the thing before that? Getting lost in familiar locations is in there somewhere. Close calls, trouble, seeing cyclists and pedestrians, depending on your environment. But that whole kind of, thinking, have a staged approach. And again, this isn't a one-time conversation usually. This comes up over time. And you need some degree of relationship to be able to have some cachet as you talk about this. Okay, so say you've done this kind of clinical history and you realize, yeah, I've got worries, I've got concerns. The options that you have in terms of cognitive screening, a lot of people, we found, at least in the state of Washington, a lot of people still use the mini-mental status examination. And you can see up here the sensitivity and specificity data is not spectacular. This is for dementia, not MCI. The mini-cog, developed by my friend and colleague and former faculty member here at the University of Washington, Sue Borson, has equivalent, if not better, sensitivity and specificity in dementia, but was not designed to detect mild cognitive impairment. It's much quicker and I think a better instrument than the mini-mental. And also, if you're using the mini-mental, technically you should be paying for it, whereas the mini-cog is public domain. And then, of course, the MoCA has the best sensitivity, specificity. It's going to become the gold standard for cognitive screening. The problem is it takes 13 minutes or so to administer. And if you've done more than a couple MoCAs, you know that there are parts of it that really don't add anything typically. So it's still kind of the best instrument, but it's not perfect either. But if you're going to use one thing, as you can see from this, it's probably going to be the MoCA. So one recent study, then a couple of older ones, this was the end of last year that this one was published, had a little over 80 individuals where the outcome was a standard road test, and they used the mini-mental. And what they found was that if you had a mini-mental of 19 and below, you weren't going to pass the road test. However, if you had a mini-mental of 27, 28, about a third of you aren't going to pass the road test. So it's not good necessarily. The MoCA is a little bit better, and this study in 2015 in JAGS would say a cut point of about 18 is predictive of not passing a road test. And then as you drop a point after about 25, you become 1.36 times more likely to fail that road test, but probably no need to do it below 18. And then another study here, which I would love to see replicated. It's a bigger sample size, but would say, if you've got a MoCA of 28, 29, you're probably going to pass a road test. This was a DMB driving evaluation. This was not an occupational therapist driving evaluation. And if you have a MoCA of less than 12, there's probably no point in sending somebody to this because they're not going to pass. However, and then kind of 50-50 in between there. However, you probably can conjure to mind somebody who has taken the DMB test multiple times until they pass. 8 is the record I can think of for somebody who they spent the better part of a year just going back and doing it again and again and again and again. They finally passed. So it's not the gold standard for driving evaluation either. Okay, so neuropsych assessment, when is it helpful? I'm also aware, like geriatricians and memory disorders clinics, neuropsychologists are kind of an infrequent resource and becoming less frequent as organizations change. And it's certainly hard to get somebody with Medicare in to see a neuropsychologist, but there are places. And if you work in a system where this is a resource to you or in a community, it's certainly helpful to clarify and detect changes where, boy, this person's got a normal cognitive screening score, but I know there's something going on. Very, very bright individuals, sensitivity and specificity, sensitivity particularly for the MoCA is kind of low. And it's not great for people with low average IQ or lower borderline. So maybe as you need to suss things out in a little bit more detail. Certainly helping with some differential diagnostic work. And not just well, is it depression or is it MCI? It's mostly MCI due to something that looks neurodegenerative, but there's depression on top of that. Decision-making capacity. And then certainly, as you're thinking about, what's someone's ability to manage their medications, their finances, their driving capacity, and setting the stage for if we're going to work on some things and we come back and reassess in a year or 2 years, have we benefited, or is this continuing to decline, and at what rate? I would also say that my approach with neuropsych eval is that you do not need a full 8-hour day worth of cognitive testing to answer the questions that I have up here. If you can't do it in a 4-hour visit, you're not asking the right questions. And certainly as you think about reassessing things, that can be very brief. When is it not so helpful? A MoCA, my usual cutoff is, unless it's mostly language that's driving a low MoCA score, where it's either expressive or receptive speech problems, where it looks so globally impaired, a MoCA of less than 12, there's really not much point sending somebody for more detailed cognitive testing. It's going to be impaired. You can do the same thing with maybe a little bit more of an expanded screening. The other thing is, I would say, never send somebody there unless they are at least cautiously optimistic about it, or willing to undergo the process, because it's nothing worse for providers or for families is to go through this process and then the neuropsychologist says, effort was so poor, I can't make sense of it. You wasted everybody's time. So that kind of unwilling, uncooperative person, it's really hard to do this kind of an evaluation. I had somebody a couple of weeks ago who thought they were coming in to see the dentist because that's what their family told them. So we didn't do much in the way of testing. Active substance abuse, unless you're interested in what's the effect of that, usually it's kind of a 3 to 6 months of abstinence, about average. Same thing with acute delirium, things that you want to resolve before, and then you want to minimize any practice effects. So about 6 months typically, although there are some ways to get around that. All right. If you are going to do that, to send somebody for a neuropsych eval, or if you're thinking about, are there tools that I could pick up from this and do myself? If you look at the literature, there's a couple of nice overviews. Trail making test is still kind of the best one that we have. And that is kind of the connect the dots, 1 to 2 to 3 to 4 to 5, measuring processing speed and visual attention. And then the second part is alternating. So divided attention, 1 to A to 2, 2 to B, B to 3. And if you take B and subtract kind of the A score as an index of processing speed, you get a little bit more detailed information around executive functioning. So there's some ways to look at that too. Clock drawing comes out pretty frequently as something value added because it's got both visuospatial and executive demands. Same thing for block design from the Wechsler Adult Intelligence Scale, Ray Complex Figure, which is spatial and executive, line orientation, which is purely spatial about judging proportions. Same thing with facial recognition, visuospatial. And then individuals with MCI who are depressed have a higher crash risk than those who have MCI and aren't depressed. So I think our assessment of not just the cognitive pieces, but the neuropsychiatric or the psychological pieces can be helpful also. I will give you an example here of an individual's TRAILS B. So this is the actual measure. This was done at the baseline evaluation, and the score here was in the lower end of the average range. 16 months later, they came back in for a repeat evaluation, and there's one error, one set loss error. Actually, nope, that's a sequencing error. So this is about 16 months later. And then 1 year later, we now have 4 errors, and we discontinued it at 5 minutes. So we went from kind of the low end of the average range to the borderline impaired range for speed with 1 error to severely impaired for speed with 5 errors. So this is, kind of, you can see the executive dysfunction kind of progressing over time. Same patient. This is the Ray Complex Figure. This is one of the most torturous tests that we have, where you give someone this figure and you say, go ahead and copy this for me. And you don't take it away. So they're just looking at the stimulus and copying the design. And as you would imagine, you're looking at visuospatial skills. You're looking at organization and approach. People with intact frontal lobes will draw the big rectangle first. If others of you out there had different ideas, that doesn't mean your frontal lobes aren't intact. You might just be a divergent thinker. But you can also then look at motor control. Sometimes people with stroke will have neglect for certain pieces, but it's really visuospatial and executive. So this was at baseline for this individual. This is a just fine score. It looks pretty good. A little bit of constructional dyspraxia on the diamond out there on the right side. Here we have 16 months later, and you can see that there's both kind of an executive, so the colored, I like the colored pens because you can just look at it and kind of see what the organization was like, but there's also this kind of distortion and the proportions are wrong. Some of that's because of how they went about it. Some of it's the parietal component too. And then here it is a year after that. And this is a great example also of this becoming progressively more stimulus bound, where it's kind of drifting up to the stimulus. The person can't disengage from the thing that they're looking at, right? So, so this also, to me, when you show this to a patient or their family and talk about why you have concerns about their driving ability, when you look at this in terms of this is how this person sees the world in a way, and what does that mean in terms of driving? That's worrisome. These came from a couple weeks ago, and I had either the good fortune or the misfortune of having an individual with posterior cortical atrophy variant, and then logopenic primary progressive aphasia due to Alzheimer's disease, 2 days, and one on Monday, one on Tuesday. And you can see the PCA on the left here, which has got spatial kind of, it's not so good. And then on the right, that's not bad. It's a little shaky, but that's not too bad. So you can see the difference there depending on which parts of the cortex are affected. And that's what it's supposed to look like. And then that Thursday, we had somebody with frontotemporal dementia. And not distorted necessarily, but I mean, this is such a lovely example of FTD in terms of the perseverative line drawing, the poor planning, where she had to cram the right side of the figure in because she didn't use the page well. And it's just really poorly organized. It's fragmented. I'm guessing that black circle up there is just crossing things out. So just showing you some of these things if you haven't seen them before. All right. And if we know that, neuropsych eval can be helpful in some ways, it also can set the stage for, you probably need a deeper evaluation, or no, you're not likely to pass that, or it's probably not going to be revelatory. You have some options. So there are clinics and organizations and places, businesses that do driving skills evaluations. These tend to be kind of like driver rehab light. Where sometimes they will sit down with somebody and look at their car in terms of, well, if you adjust the seat this way, or maybe change these things, it might improve your visibility and your ability to operate the pedals. There may be some analysis of, what do you think are the concerns about your driving abilities? They sometimes offer training, so specific training. So think of this as like kind of driving school in a way. And they might recommend a more detailed evaluation. It's not the cheapest, and it's probably not going to add a ton, but it might be all you have, and it might be enough to say, well, this isn't going well, and you probably should think about other plans for community mobility. What you may have more access to through occupational therapy or a certified driving rehabilitation specialist is a more comprehensive assessment, and these are the components. So there's a clear medical history around risk factors, medications. They usually do things like a timed up and go test to look at strength and balance and agility, useful field of view, so kind of how big of a range is there. They do a cognitive assessment. Typically trails A and B are part of that. And in most OT or driving rehab specialist evaluations, the cutoff on Trails B is 3 minutes and no mistakes. So in order to quote unquote pass that part of it, you have to do it within 3 minutes and not make any mistakes. And then there is the on-the-road assessment. And these are a little different depending on where you go. So some places, they have their own vehicle and you have to kind of drive around a parking garage or a parking lot. Others will come to you and drive in your car, or have you drive in your car in your environments. And the nice thing about this is it's not a binary, you passed or failed. It's usually well, here are the areas that are a little bit weak. Here are some things you can work on that might strengthen those. Here are the driving scenarios where you seem safe. So under 35 miles an hour, well lit, no distractions, so the radio's not on, you're not talking on the phone, you're not eating, you're not even talking, you're driving, right? So they make recommendations. And then some places actually do rehab as well. And again, remember from our American Academy of Neurology practice parameters, it's kind of unclear how effective rehab really is. Not cheap, insurance doesn't cover this typically. I have heard that if the occupational therapist bills it as a community mobility evaluation, some insurance companies may cover it, but there's no guarantee that that happens. So things to know. There is, this is it's becoming a little older now, back in 2013, but there was an interesting kind of cognitive rehab, cognitive training study with older adults and younger adults. And this was one of those studies that was cited because one of the findings was that things that younger adults could do, namely the sign and drive task down here on the right, which is you have to pay attention to where you are on the road, then you have to react every time the thing in your rear view mirror there goes from green to red. Younger adults can do that with kind of one lateralized hemisphere of the brain. Older adults took both to do it and weren't quite as effective. There were a few studies that kind of had similar findings around that. But what they found here is that if you trained older adults for a month, and then at 6 months, they kept doing it, at 6 months there were no differences between older adults and younger adults. How this translates into real world driving, I don't know. They didn't pair it with a driving road evaluation, but interesting. And certainly there are tons of companies and other things that want money for cognitive rehab and training, but the data is really murky. But interesting, threw it in there for your consideration. So driving with dementia, a couple of other kind of things to be thinking about. One would be that if somebody did pass a driving evaluation, it should be reevaluated at 6 months. And typically what we tell people is that you have something that's likely going to be progressive. Right now, it sounds like you're doing well, and these are the ways you can stay safe and the modifications that were suggested. We will reevaluate this in 6 months, and in between now and then, we want somebody at least once a month who is appropriately vigilant riding with you to collect some data. And most people are begrudgingly okay with that. And then, again, if we followed them over time, at 6 months, 4 out of 7 have now failed their driving evaluation. And as the disease progresses, again, everyone will retire from driving or won't pass a driving evaluation. So it's really kind of setting the stage that would say we need a plan because you're not going to be driving forever. So that brings me to the how do you have that conversation and what can you do, what can you recommend? I think it's critically important to validate that this is very, very difficult. And to share in that this is such a hard thing to think about. This is such a difficult change. It's hard enough to lose short-term memory and all these other things, but now to have your independence and your identity threatened, but you can't stay stuck in that, right? You can validate it but we need a plan, right? And this idea that this is a continuum of things that we can do. We can start early and kind of set the stage and revisit this. We can think about some restrictions and limitations and see how that goes. Maybe it's not so bad. You think it's going to be terrible, but if you don't drive in these scenarios, see how that feels. Give it 3 months and we'll come back and talk about it. It is occasionally helpful to have the quote unquote experts weigh in, even if you know what the outcome's going to be. And then, late stage is, the stuff of I took the alternator cap out of the car or we changed the keys. And that doesn't always work. You may know people or have heard stories where somebody goes out and gets a new car, or they call the mechanic who comes from the shop to the house to fix the car. So you need to get really creative sometimes, and you need to get rid of the car sometimes. Although I can also tell you a story of somebody who went out and bought a new one. So it becomes this kind of global intervention of, it's not just about driving, it's about the bank who makes the loan for the car and the car dealership and the mechanics. You kind of all have to, not quite collude, but you all have to be cooperative about this. The other thing that I have found helpful, and this takes time, is this kind of combined sense of responsibility and education. So a lot of people don't know the legal and financial risks. And I will typically, I typically use the words retire from driving instead of quit driving or stop driving. And I will typically share some information around, if you were to get into a questionable fault accident and it's not clear at the scene of the accident or the time whose fault it was, if the other party's attorney requests your medical records because they're looking for a medication or a medical condition that would put the fault in your court, your insurance company may not cover this, particularly if we've had this conversation, and the liability may be on you. So kind of harnessing someone's pride about their driving legacy. I've never had an accident. I've been driving for 65 years. I've never had an accident. What an amazing legacy to preserve. Let's not undo that with something horrific that could happen now. Sometimes that works. Sometimes you plant that seed and it's like, but you have to come back to it. Right? And, you also have to kind of maintain awareness of your own, I'm just going to mandate that you do this and we're not going to have this conversation. It's tough. You have to kind of roll with the resistance with this sometimes. And certainly you need to stay up to date on resources. Helpful sometimes to talk with families about concrete things they can do. And sometimes it's the, I don't know if you could drive or not, but your doctor said you can't. Kind of putting the blame on the provider. It's imperative that the cues aren't there. And I can think of a story from about a month ago where it was around a holiday and one of the grandkids, well-meaning, who had just got his license, was all excited to talk about driving. It was like, I think I'm gonna go out for a drive after dinner. And grandma wanted to go driving too. So just doing some of that education around, you can't really talk about this. And then of course, avoiding confrontation. There's this art of gentle deception sometimes in dealing with some of the behavioral and neuropsychiatric sequelae of dementia, where you got the agitated individual looking for their keys, and you can validate it's going to be so frustrating not to be able to find your keys. Let's go look for them. Let's go out here and look for them, and you're going to go do something else entirely, right? And maybe you can redirect and get past the point where that's an issue. Some community resources. These are not uniform across states. They're certainly not uniform across regions, but the Department of Licensing is a good one. And there are some really interesting programs through either AAA or through other places where if the senior does this and they do well, they can get a discount on their insurance. It's a good update for safety things that we forget about sometimes. And then of course, through your Department of Licensing, anybody here in the state of Washington can request a reevaluation for driving. Doesn't have to be a provider. Doesn't have to be a MD, DO, ARNP, PhD. Anybody can do it. Family member, neighbor. But you have to know some of the nuances around reporting. So here in Washington, providers are permitted to refer somebody for an evaluation. It's not mandatory. Unlike suspected abuse, you're not a mandatory reporter. The challenge is it's not confidential. So if I were to recommend that one of my patients get reevaluated, they could contact the DMV or DOL and say, who ratted me out? This is true for family members too. But they do get a letter, and then they have to go do the evaluation. And sometimes there are places or scenarios where it's enough to say, given the severity of the disease and the concerns I have, this person should not be driving, and you should rescind their license. That can be done too. Here's the reporting form. That's it. It's all you have to fill out. Other kind of resources that you could point your patients to, or you can take a look at. So AAA has a really nice senior driving website. There's all sorts of things there about medications and driving for older adults, kind of other safety issues, refresher courses. Some of these interface with insurance, some of them don't. They had for a while this online, it was a CD-ROM or an online program where you could do a little mini driving assessment. It's not active right now, and I don't know why. It did need some updating, but I wonder about liability with this, because it was something that people would do, and they bring in the printout and say, look, I did this and I passed it. And who knows who actually took it or how many times they did it. But also great resources for family members from the Hartford group here, kind of difficult discussions around dementia and driving, family conversations with older drivers. Other community resources that, again, vary across the state. Certainly your area agencies on aging, now kind of community living connections are great in terms of what's available for access or other transportation assistance. So the American Parkinson's Disease Association has a ride reimbursement program. So people with Parkinson's can take a cab to their medical appointments. I think it's mostly medical appointments, but then get reimbursed for that. So different organizations. I know the Alzheimer's Association was thinking about something similar. And then there are some transportation benefits if your patients are veterans. So these are things to be thinking about. Each county here in Washington has an area agency on aging. Sometimes they serve more than one county, so it may still differ. But I would direct you to the website here. And then the Community Living Connections site kind of looks like this. So you can get a sense of what's available locally. I am consistently amazed as I do more work around the state and with the state plan at how often resources change. Something that used to be funded now isn't. These kind of grant things that were kind of maybe research-based have now become permanent. So it's worth checking, even if you have this kind of pervasive sense of dread that there'll be nothing out there. It's worth checking out. All right, so let's go back to our case study here. So you remember she's the 73-year-old female with maybe depression, maybe vascular, might be Alzheimer's, might be all three. And we went through all of her risk factors here. Her 13 vitamins and supplements were a mystery to me. I had one of our pharmacists take a look at it, and she did the classic, I can tell you what this one does and what this one does, and maybe the interaction between these two, but the interactions between the interactions between the interactions, I have no idea. So that was a point of, most of these are probably harmless, but I'd worry about a couple of these things. Okay, so here's her cognitive data. So again, she's 17 years of education, so she's very bright. Her MOC is fine. You know, again, cut point of 26. She's got a 27, so she misses all three on the delayed recall, but gets them either between the multiple choice or the stimulus cues. Her premorbid estimates would say that she's either in the high average or superior range, which again fits with her educational and occupational history. In my mind, that, you know, if you think about a standard deviation and a half from that, 2 if you're going to be conservative, that would say lower end of the average range, upper low average range is probably a reliable change. And the other thing in my view of neuropsych assessment, the one thing that's nice about it is when you've got multiple measures, if 2 out of 3 in a particular domain are impaired, you're more confident that there's a reliable change here. So for her, we've got impaired verbal memory, both on well-organized information as well as list learning, kind of higher order things. Her visual memory is also impaired, not so much on the initial acquisition, but on the delayed recall. Worse for things with increased organizational executive demands like verbal memory. Her visuospatial skills are variable. Her ability to copy complex figure or simple to increasingly complex figures is okay. But her block design's impaired more because of organization. So this is a task where you have to put blocks together to make different designs. It's not that she's got the design wrong because it's all rotated or distorted. It's that she can't kind of organize her approach to the task and spends too long on it. Line orientation's kind of iffy. visual integration. So the Hooper is a test of, I'm going to show you a picture of something that's been cut up and all the pieces are kind of spun around, and mentally you have to integrate it and say what it is. Her language abilities, her phonemic verbal fluency, so tell me all the words you can think of that start with a certain letter is okay, but semantic is low average. Her naming abilities are low average, so we've got some suspicion for difficulty with access to the semantic or lexical store, I think in temporal lobes now. And her writing abilities are not so good. Her receptive speech abilities are fine. The executive functioning is also variable. So borderline impaired on an inhibition trial. So the Stroop is one of our other favorite things that we love to torture people with, which is first I'm going to have you name all these words as fast as you can, their colors, and then their X's, different colors of ink. Say all those as fast as you can. Now it's the word green, but in blue ink. I want you to say the color of the ink, not the word. So you have to inhibit the thing your brain wants to do. Trails B, which you've seen, she's got 2 set loss errors, and she's in the low average range. Tower of London is a nice measure of planning and organization. She's got a lot of rule violations, kind of inhibition problems. Her Ray complex figure was fine in terms of its spatial properties, but organization wasn't so good. And her performance on a measure of abstraction, concept formation was variable. She did okay overall, but just kind of didn't quite get it. And she's not depressed, and a little on the anxious side. So these are the summations of her results. So what's her diagnosis, and is she safe to drive? Given that there are 3 people here in the room, I'm hesitant to put anybody on the spot. And given that it'd be nice to be able to take maybe 10 minutes worth of questions and answers is, so her diagnosis after this evaluation, she actually went and had an amyloid PET scan, which we were doing those as part of the IDEAS trial. She has kind of a frontal variant Alzheimer's disease. So her brain is full of amyloid plaques. It's not the classic kind of mesial temporal lobe involvement that you would fully expect, but I would suspect that if we were to do tau imaging with her, which we can do, but you need to be part of a research study, you would see she's got distributions primarily in the frontal and the parietal lobes with some mesial temporal lobe involvement, maybe right greater than left. And given that she's got the executive and the spatial skills, at this point, her diagnosis would be MCI due to Alzheimer's disease, multiple domain, with a high risk for progression. Given the changes in executive functioning, more complex attention, we ended up sending her for a driving evaluation, and she passed. But she narrowly passed. And the story was the certified driving rehab specialist wanted to see her back in 6 months. She did not pass that evaluation. And it was a chance within 6 months to start working on both medication interventions as well as starting to have the conversation around, boy, it sounds like you did this evaluation. Glad it went well. These are areas of concern, high risk for this getting worse over time. What can we put in place? And that's an ongoing conversation, but that's kind of a picture. I'll leave that up. Just my contact information, which you should have in the handouts also. But so I am happy to take some questions. I think we've got about 10 minutes or so.
Mm-hmm. So I already have a question, if I can. Oh, sorry.
No.
So you had talked about a court case earlier, and a question came on pretty early about the result of that court case, and was the person charged?
She was charged, but it actually it resolved before the trial started. I think with what ended up happening with that was, of course, the Secretary of State would not have all of the medical records or all the extenuating factors around that scenario. And as there were some depositions and as things came to light, I think it was okay, this is someone that we don't need to necessarily prosecute. But I'll tell you, doing depositions around a matter like that's not much different than going to court. So it did not go to trial, but it certainly could have. She was pretty elderly too. She's in her late 70s. And there's a question here in the room, which I'll repeat for those of you out there.
Yeah, so after the evaluation, are these
That's an excellent question. So the question was, with the evaluation process, are these conversations that are happening kind of right then and there, or is it at follow-up, or what does follow-up look like? And for our clinic, I'll give you two answers to that. I'll try to be quick. For our clinic, we get referrals from all over, including self-referrals. What usually happens is they come in, they see one of the attending providers who decides what's the right diagnostic workup. Is it imaging? Is it neuropsych testing? What are the labs need to be done? They go do that. They come back for a family conference. And at that point, I mean, you've already kind of broached driving at the first visit, you've broached it in the neuropsych eval, and you can bring it up at the family conference, but that's not really the time, because that's usually a disclosure visit where it's boy, I'm sorry to tell you this, but these deficits are due, what it appears to be due to underlying Alzheimer's disease or Lewy body dementia. But then what happens is we follow up, within maybe 3 months, we have a social worker that makes contact. And it's certainly at the 3 or the 6 month follow-up, it becomes a bigger part of the conversation. It's also something we're trying to partner with primary care providers on in terms of, did this evaluation, and if it's we think you need a driving evaluation, there's an opportunity for the primary care provider to get involved there. So it's usually the subsequent visits. And then, as I mentioned on the front end, I do rehab follow-up. Sometimes I see people once a month. Sometimes I see people once every 3 months, 6 months. And it's usually, I get to spend an hour with people, so it's easy to weave it in as it becomes pertinent. For primary care providers, sometimes it's a more gradual conversation, and kind of like with screening, we're working on a protocol where you might do something brief that sets the stage for a more expanded assessment. Trying to think of driving the same way, where you can kind of plant some seeds, but then you have to come revisit it and hope that nothing happens in the interim. Other questions?
Yeah, so I've actually had a couple of questions asking about the statement that you made earlier about road testing not being cost effective. I think that was with
I think, yeah, that would be with the full-on certified driving rehabilitation specialist. Sometimes upwards of $400 per assessment, and you can't do that with everybody who has concerns, especially if it's not going to be reimbursed by insurance. DMV assessment is probably cost-effective in terms of, I don't think that costs very much, and it's certainly more uniformly available. The problem is it's not real sensitive and specific. And I've heard conflicting results. So here in the Seattle area, I just saw a family a while ago who said their driving assessment was closer to $800. And I'm not sure where they went or who they had it done by, but it was not cheap.
And then a question, how do you deal with HIPAA interviewing families and caregivers?
Oh, yes. So a couple things. We, at the outset of the visit, we have them sign a consent form for whoever, or a ROI for whoever they want to be involved in their care. And you can address that a couple of ways in terms of being able to communicate results to patients or to family members, or sometimes even they want friends, or being able to receive information. And then during the actual clinical interview, I will ask and then document, while you're working on the cognitive testing part of things with my technician or psychometrist, would it be okay with you if I talked with your wife for a little bit and get her opinion about some things? And rarely do people say no. They do sometimes, and they say, okay, well, we can't. But then I will document that in the note also. Yeah, I think the days of being able to assume it's okay to talk because somebody accompanies them to the visit are over, and maybe rightfully so. But yeah, we usually will ask, like, do you have a child or a sibling who lives out of state who's likely to give us a call and want to talk about your care? And if there is, would you be comfortable signing a release for that? And then we scan it into the medical record. And usually they're puzzled in terms of, well, it's my daughter. Why do I have to sign a form? Well, yeah, you do. So.
You mentioned early in the presentation something to the effect of Alzheimer's disease versus Alzheimer's dementia, which was confusing to us. Can you explain this?
Absolutely, yeah. So thank you for that. And I've got if I trusted my ability to navigate the technology here, I would show you a better slide. But so you think about Alzheimer's disease is the presence of amyloid beta and tau accumulations in the brain. Those are the pathological hallmarks of Alzheimer's disease. So you can have the disease, and that usually starts 10, 15 years before the clinical symptoms of memory loss or language problems or spatial problems or executive dysfunction are present. So that if we go back to, I remotely trust my ability to do this. If we go back to this slide right here. Right there. Okay. So we have here this kind of pathway of, and if you could imagine, as this red line is going down, there's another line that kind of starts at the intersection there that's going up. And that's the gradual accumulation of the pathological changes in the brain. So I could have Alzheimer's disease, meaning I've got plaques and tangles, but I don't yet have symptoms. And then if I get more of those plaques and tangles, it might cause enough damage in the brain that I've got mild cognitive impairment. And if that continues to go on, now I've got Alzheimer's dementia. So, so that kind of difference of disease versus consequence of that disease. Right? So not everybody, I guess the analogy would be, not everybody with diabetes loses their toes or their eyesight. I don't know if that's a good analogy, but it's the best I can come up with. And again, as we think about treatments, if we can suppress that accumulation, we can you still have the disease, but you don't develop the dementia maybe. But yeah, that's a good question.
All right, well, we have gotten some feedback to say thank you for doing this in a rescheduled sort of way.
Oh, my pleasure.
Pretty important information, so thanks much.
Yeah, happy to.